Yeah, so Etentamig is a BCMA-targeted bispecific antibody that has some unique properties associated with it. The Etentamig has again a bivalent BCMA binding, so it certainly can bind with a higher ability to the cell surface BCMA on the myeloma cells. It also has a low affinity CD3 binding, which again leads to reduced cytokine release and the potential for minimal T cell exhaustion. And it also has a silenced Fc tail, which allows for a more extended dosing strategy with every 4-week dosing. So what was presented was again the long-term results from the 146 patients who were treated with Etentamig in the initial studies. Again, this was a relapsed patient population with a median 4 prior lines of therapy, and with a little over a year follow-up, we know that the overall response rate in the overall patient population about 66%, and the VGPR rate was about 54%. We also looked at the subgroups to see if these responses were different, and we found that the response rates were fairly similar across the board, irrespective of the age, the high-risk cytogenetics, the number of prior lines of therapy, and so forth. The median duration of response was not reached, but the median progression-free survival also was not reached. But the estimated 1 year was about 55% for the PFS and 71% for the duration of response. So in terms of toxicity, again, we found fairly similar toxicities as we would see in the setting of other bispecific antibodies. The cytokine release syndrome was predominantly grade 1 or 2 and very easily managed. And the median duration time to onset was under a day. Very few patients had recurrent CRS. The infection signal was again very consistent with what we have seen before. No significant new adverse events have been seen with the longer term follow-up. And the grade 3 for infection rate was approximately 22% in these patients. Again, very similar or less than what we have seen with other bispecific antibodies. So in summary, I think Etentamig represents a BCMA-targeted bispecific antibody with a more convenient dosing and a toxicity profile that is comparable or better than what we have currently available for patients with multiple myeloma. And the ongoing phase 3 trial is going to be exploring this in the 1 to 3 prior lines of therapy against the standard of care regimens.